from about the 27th, when we had like 3 cases, it was a gentle rise till about the 24th of March, and it has started to rise, and it's rising pretty steeply and doubling almost every, well, not doubling yet, but is rising very steeply. So Africa is moving very rapidly, and we're beginning to see a lot of cases. As of today, a lot of cases, most of these cases appear mild. We have not recorded too many deaths, considering that this is a whole continent, but they're beginning to rise. We have over 800 deaths already. SARS-CoV is something that is an organism that there's still a lot of controversy, political, medical, about where it came from. But we do know that it's similar to SARS-CoV-1, that's the SARS virus, and MERS-CoV, but it's not the same. And the exact origin is not yet known, but it appears to be from a bat, but we do not know exactly through which animals it might have crossed over into the human species. The transmission, human to human transfer, by inhalation of droplets that are expelled from infected persons. Through coughing, sneezing, we now know, and talking and singing, or by contact with respiratory secretions, and this is moved through the hands to the face. The incubation period appears to be 1 to 12.5 days, with a median of 5 to 6 days. Most infections will occur through symptomatic patients, but we do know that there's an early shedding of virus from infected persons, even when they are pre-symptomatic. Some studies have shown, a particular study in Nature showed that you could detect this virus early, a few days before, or a few days before symptoms were clear, but that the peak viral loads occur within the first 5 days. In other words, patients are extremely infectious early in the disease. And that shedding could continue for 7 to 12 days in patients who are mild to moderate. And in some cases, they found that patients were still shedding 20 days post symptoms. COVID is infectious, but it's more so because infection can occur before people show symptoms. So normal people are going around and can infect. But in terms of the R naught, it's about one person infects about 2 to 3 people. And if you compare that to other diseases like measles that have much higher infectivity, it is highly infectious because we do not know. It's very similar to Ebola, but the difference is Ebola, people have to be symptomatic to transmit infection. This is dangerous in the sense that normal looking people who don't appear to have any symptoms, or who have such mild symptoms they may not even recognize it, can spread the infection. And the things I'm saying here those are the things that inform the infection prevention and control strategies that have been developed. I'll just run through. So symptomatic patients, most of them will be mild, fever, headache, dry cough. In more severe cases, there'll be shortness of breath. And some patients have been shown to have diarrhea, nausea, vomiting. But in severe cases, you could have severe acute respiratory disease syndrome, pneumonia, bronchitis, and kidney failure, and death. Luckily, most infections do not require hospitalization. At least 80% of patients will not require hospitalization. Another 15% of patients will have moderate to severe disease, and only about 5% will need ventilation. The recent case definitions for suspects, and they change. This is as of March 20, that a patient with acute respiratory illness, fever, and at least one sign or symptom of respiratory disease, e.g. cough, shortness of breath, and a history of travel to or residence in a location reporting community transmission of COVID-19 disease during the 14 days prior to symptom onset. 2, a patient with any acute respiratory illness and having been in contact with a confirmed or probable COVID-19 case in the last 14 days prior to symptom onset. And, or C, a patient with severe acute respiratory illness, fever, and at least one sign or symptom of respiratory disease, e.g. cough, shortness of breath, and requiring hospitalization, and in the absence of an alternative diagnosis that fully explains the clinical presentation, should be considered a suspect. A confirmed case is one in which there is a laboratory confirmation of the disease. So who is vulnerable? Everyone is vulnerable. Everyone can be infected. And even if people have mild to moderate disease, they are dangerous to others because they can transmit it. The severity of the disease appears to affect the elderly, people with underlying disease, such as diabetes mellitus, asthma, or people with other diseases. And most deaths to date have been found in old people and people with underlying disease. However, some people don't seem to have underlying disease and have died. In Africa so far, in many countries, the disease appears to be relatively mild to moderate, but we're beginning to see more deaths. And this might have to do with the stage of the epidemic. Because as we start to have more sustained transmission in the community, then we might start to see more deaths in the vulnerable population. Some of the things people have talked about about Africa is that we have a very large number of young people below the age of 35. However, we do have also old people. The other part of it that in terms of vulnerability, because some people have said that because we have a young population, it's not likely to be severe. But Africa also has a lot of displaced people. We have a lot of poverty. We have a lot of people who are malnourished. How this will play out as we watch this epidemic, if it continues to go on, we're not sure, but it's something that we need to keep an eye on. Thus far, there are no commercially available antibody tests. There are some that exist. Most of these have not been validated, and many that have been validated are not very good. It's important to mention this because a lot of tests are being touted and being sold to people to laboratories in Africa for testing. They are still not validated. The most common samples taken are nasopharyngeal swabs and sputum. And identification at this time is through real-time PCR. And the genome sequence available through the World Health Organization, available for, and it's shared. So far, infectious viral particles have not been detected in urine, blood, and stool, though viral RNA have been detected in stool. Treatment. There's still no treatment, but lots of clinical trials are ongoing. Hydroxychloroquine, remdesivir, and so on. There's still no vaccine, and a vaccine is not likely to be available for the next 1 year, at least. Treatment is, by and large, supportive therapy, and related to patient symptoms. Therefore, infection prevention and control to limit exposure is a key strategy in containing this disease. What strategy is applied depends on what stage of the epidemic we are. It would be ideal if everybody is absolutely prepared. Right now, the disease is ravaging many countries, and Africa is clearly becoming more infected. The northern regions are a lot more infected than the other areas. So North Africa, followed by West Africa, then South Africa, East Africa, and Central region. The number of cases we have in Africa now per country is some from 0 to over 2,000 cases in the countries. We have at least 2 countries that have not yet recorded any infection. This I got from the WHO, Principles of Emergency Treatment, just to show the cycle that goes on in preparedness. The strategies that can help our facilities to prevent and reduce the impact of an emergency, that's prevention and mitigation. In preparedness and readiness, the actions that take place before an emergency. For response, the activities in reaction to a known or suspected event. And during recovery, evaluate the prevention, mitigation, preparedness that occur and how to get back to normal. Most of Africa at this present time are in prevention and mitigation, preparedness and readiness, but many are in response, none yet in recovery. Okay. So, the WHO guidelines have identified a number of some key strategies that would allow for the highest level of effectiveness in the response to COVID-19 in terms of IPC. 1, there must be an IPC program with a dedicated and trained team, or at least an IPC focal person who is trained and understands IPC. Irrespective of whether the program is dedicated or the team trained, if it's not supported by the national and the facility senior management, it's not going to be effective at all. Any team to work well must understand the principles of IPC and understand the basis for addressing risks in IPC. In countries, however, in countries where IPC is limited or inexistent, it doesn't matter. You start where you are by ensuring that at least you have the minimum requirements for IPC, which again has been given by WHO and is available on their website, the minimum requirements for IPC. So you start where you are and you move forward, both at national and facility level. And wherever you are, you work to achieving both the requirements of the IPC core components according to your local priorities. The IPC core components for any effective program is captured in this diagram. You have the IPC programs, which are relevant program linkages. The guidelines, you must have education and training, you must have surveillance, monitoring. So the IPC program sits on the fact that you have all these guidelines, the education and training, surveillance and monitoring. But for these to work, there must be an enabling environment. And this enabling environment means that the staff who are the staffing must be appropriate. Their workload must not be too heavy, because we do know that staff that are overworked make mistakes and may not do, and then Bed occupancy is also important. The more overcrowded, the more likely there will be transmission because then people are in close proximity. And all this can only work if they work effectively in a proper environment where you have water supply, you have equipment to work, where the environment is clean and so that people can work effectively. Now, for one to achieve a good program, many things have to be done at the same time. You have to employ many strategies. A big proportion of IPC is about behavior change. And if you do not, so that the healthcare workers must change behavior so that the program can work. Required for them to change behavior, it must be made easy. So there must be many ways in which, apart from training them, there must be a proper environment for them to function, with the tools to work with the reminders in the workplace, things that help them to remember what to do. There must be someone monitoring what they're doing and giving them feedback and encouraging them to continue to work better. All these are required for an infection prevention and control program to function properly. But we know that this does not always happen. But despite the fact that one does not have everything, one can start wherever one is and start with the trained person, start with the environment, and move gradually till you can achieve all these elements. So, just to go over that, the components of an IPC program, you must have the person, you should have the committee and team in place. The bigger the hospital, the more people are required. You need a team. A very small facility might just need one person. The larger the number of patients that will be seen, the bed spaces. There are ratios, 1 to 100, 1 to 250. Irrespective of the ability to have these ratios, at least start with one person. The guidelines are important with the SOPs that spell out how people should work. Then there must be standard precautions, transmission-based precautions. And in whatever one does, there must be surveillance of the infections that we have and the organisms that exist. Training is a major component of IPC practices. I don't know where this thing is moving. So, in COVID-19, the strategies for effective IPC have been properly enumerated, and there are 5. It is important to ensure triage, early recognition of patients, and source control. In other words, isolating patients with suspected COVID and taking them away from other patients. Applying standard precautions for all patients. Implementing empiric additional precautions, and these are droplet and contact, and whenever applicable, airborne precautions, which I will mention later, for suspected cases of COVID-19. And implementing administrative controls. These are having the right policies, the guidance, the work schedules, etc., that would allow staff to work effectively and safely and create a safe environment within the facility. And then using environmental and engineering controls to eliminate or substitute all the risks that may exist. For example, having a negative pressure room for airborne, or making sure that there's good ventilation when carrying out procedures, and so on. Now, all the IPC procedures are based on the chain of disease transmission, understanding how organisms move from host to host, and ensuring that whatever is done prevents that movement. And we call this the chain of disease transmission. This is familiar to many, but I also know that not everybody has tied that to all the IPC strategies that we do. Now, for any organism to cause disease, it must leave its reservoir. And from that reservoir, in leaving that reservoir, it must leave through a particular portal of exit. In the case of COVID-19, the SARS organism is a respiratory virus, and it is carried in human beings. And this speaks to why presently in Africa, many of countries are in lockdown, because we know people transmitting the disease are not necessarily showing symptoms. And so what is happening is we're trying to keep those with infections that do not know at home, so that they do not continue to transmit to others. Once it leaves, and the portal of exit is from the respiratory tract. It's not from the skin, it's not from the eyes. As I said earlier, it has not been found in blood, it has not been found in urine. Only the RNA has been found in stool. So the transmission is still respiratory. And so it's coming out of people's mouths and people's noses. Once it comes out, because this is a droplet infection, in other words, the size of the droplets that come out when we talk, when we sing, when we cough are quite large. They will drop not too far from the person coughing and tend to fall and contaminate horizontal surfaces. Because of that, the hands can transfer. If you touch these surfaces, then it can transfer these to your face. Then you could breathe in the virus. So it still has to, no matter what, the whole issue of sanitizers and so on is because it's to prevent us transferring the virus that we have picked up from surfaces around us to our face. And I'll explain why I'm going on and on about this. Now, once it's transmitted through the mode of transmission, it can be transmitted directly by coughing into the face, and it's landing straight into the mucous membranes of the susceptible person, or it has dropped onto surfaces, and because of this, hands can transfer to the face. And of course, it can also contaminate the clothes that are being worn by healthcare workers. Once the patient is infected, then once it's transmitted, it has to enter into a susceptible host. And it has to enter through the portal of entry that makes it possible for it to cause disease. In the case of COVID, this again is the respiratory tract. So it has to get back into the respiratory tract to cause infection. This is particularly important because it also guides the choice of PPE that we use. There has been a lot of panic amongst healthcare workers concerning the choice of PPE. But if we remember that the PPE seeks to do a number of things. The first one is to prevent, as much as possible, exit of this organism from its portal of exit. And for that, you will use a mask. Then the PPE also seeks to protect the portal of entry and prevent the microorganism from the COVID-19 and the SARS-CoV from entering the susceptible host. Again, you need a mask. And then it tries to break that transmission. The hands being the greatest culprit. hence the choice of hand sanitizers or hand washing, whichever one you can do. And it's important because the virus has a lipid layer. And when you wash it, lipid and soap breaks it up, so it renders it inactive. The same thing is what alcohol does. So the importance of two things: making sure we do not spew the virus into the environment. In other words, we keep coughing into our elbow, into tissue. Masking as healthcare, masking patients who are coughing will prevent those patients from contaminating the environment. Proper using hand sanitizers and washing our hands prevents that mode of transmission. In addition, proper cleaning, because you need to clean those surfaces that have been contaminated. At this point, let me mention, there is no need for spraying with chlorine all over the place and keeping like an Ebola thing, which has been done by a lot of people. Then the portal of entry. Healthcare workers are in their masks, and it prevents the entry of this organism into the respiratory tract. I will talk a little bit more about this. And so for any organism to cause disease, therefore, it must leave its host. It must reach a susceptible host. And it must enter the body of that susceptible host through the right portal of entry. In other words, through the susceptible area. Because if SARS-CoV falls on our legs, it's not going to cause an infection. If it falls on my clothes, it doesn't cause an infection, not in a direct way. It cannot penetrate through wounds. And then when it enters through the respiratory tract, it must survive the immune system. And after surviving the immune system, then it will multiply to the large to cause an infection. So at many points in that line, the whole infective process might be aborted. And then for it to be an effective pathogen, it must leave the host and infect someone else. So at all points, IPC comes in to prevent it from leaving the host, to prevent it reaching the susceptible host, to prevent it reaching the susceptible part. Right now, we don't have anything to help it to survive, to help us to the immune system. Our immune system still has to deal with it on its own and prevent it on its own. And then we find ways to also prevent it from leaving the host again. So the principle of disease transmission, therefore, and for things to spread, we have direct contact, touching an ill patient, etc. And the way to control that, use gloves, gowns, masks, visors, etc. Droplet transmission, which is inhaling droplets that are up to quarter meter in diameter for persons within a 1 meter to 2 meter radius. So again, the control are gloves, surgical masks, gowns, masks, and visors to protect the mucous membranes from the droplets that can and contamination of our clothing. And then there is airborne transmission. COVID is not transmitted in the airborne. It's not transmitted by the airborne route. However, it is what you would call an opportunistic airborne pathogen, in the sense that under certain conditions, where in the healthcare facilities, doing certain procedures, it can aerosolize the secretions and aerosolize this virus. And so under those conditions, and when you're carrying out those conditions, which we shall mention, we need to use the airborne precautions. Vector transmission has not been shown to be involved here for COVID. So for COVID, direct, droplet, and airborne for aerosol generating procedures. So I'm back again to breaking the chain of transmission. So to control any infection, we must break the chain of transmission. In other words, we remove the reservoir or the organism, which is source control. We interrupt the mode of transfer or prevent acquisition by new host. And so these all speak to the screen, isolate and notify, triaging, early control, recognition and source control. We require standard precautions, droplet contact precautions, airborne for aerosol generating procedures, administrative controls, engineering and environmental controls. All these we shall be discussing in more detail in the following weeks. Today, I'm just going to sort of introduce them so that we can move on to discuss them more fully in the next few weeks. So, going by what I have said, infection prevention and control, therefore, is about eliminating, substituting, minimizing, or preventing the risk of acquiring infections during the provision of healthcare services. And the strategies to break this chain, and this is not exhaustive, source control, to eliminate that reservoir, but the reservoir in COVID is a human being, so we isolate them. Or we treat them quickly, but in COVID, we really don't have a treatment yet. We manage waste, infective waste that comes from the patient. We make sure we clean the environment so that contamination of others does not occur. And then we use PPE. For patients who are coughing and cannot do a proper cough etiquette, then we put a mask over them. Interrupting the mode of transfer, hand washing, hand hygiene, cleaning, disinfection, and sterilization. Our cough etiquette, using water and sanitation and hygiene, making sure the toilet is, when we flush, we cover the lid, making sure that there is toilet, making sure that there is running water, all the things that are required to ensure a clean environment. And of course, wearing our PPE, gloves can help if properly used. And then protecting the susceptible host. You could move a susceptible host away from others. You could give prophylaxis, which we do not have. We do not have vaccination either. But we can also protect the susceptible host. We don't have right now PPE to protect the susceptible host, except he wears masks, which is the best that can still occur at this point. So, when we look at the strategies that have been discussed for preventing infection or for our IPC strategies, standard precautions is extremely important. And it is important because it's something I would just like to emphasize. For many of our hospitals, we do not do standard precautions till we've had the first case. The whole idea of the standard precautions is that we have put all these in place. It's the whole idea of the preparedness, that we've trained the people, we've made sure that there's facility for standard precautions and that people know how to use them and that there are people ensuring that it is done consistently. When we wait till someone dies, which is the story with Lassa fever, which is the story with COVID, it's when somebody gets it in the hospital, then everybody gears up and we start to do standard precautions. But standard precautions are the measures that we take whenever we're going to do healthcare, irrespective of whether that patient is, or whether the patient has anything that you think is infectious or not. So it's something we do at all times when healthcare is, when we're administering healthcare, and anywhere we are doing that, whether in the hospital, in the community, in the vehicle. And these are simple procedures. And anytime we're in contact with patients, we must do hand hygiene according to the 5 moments of hand hygiene. That says that you must do it before aseptic procedures. You must do it after touching a patient. You must do it before touching a patient. You must do it before touching body fluids, and you must do it after you've touched the environment of the patient. So these standard precautions have to be done. This hand hygiene has to be done regularly. Then you must have protective clothing. The choice of protective clothing is dependent on the mode of transfer. For example, if you think about how COVID is transmitted, then the choice of protective clothing, of PPE, should I say, the most important will be anything that would prevent it from coming out of the respiratory tract, and anything that would prevent it from entering another respiratory tract, and anything in between that would facilitate the transfer into the respiratory tract. So the masks are the single most important choice of PPE in the healthcare worker, and the gloves, to make sure that, well, the mask, then the others, gloves, hands, which are all, and gowns, which are all things to protect your clothing from contamination. How we place the patient is important. And this happens whether it's for COVID or for any patient. For droplet infections and for airborne infections, or for any of these organisms in which we already know their mode of transmission, it is always better if we can put them in a single room. But if we cannot, then patients that have the same diagnosis, the same organism, can be put together in a particular ward and cohorted so that they all have exactly the same thing, so there's no danger to each other. But you cannot put suspect patients with patients that are already confirmed. We've talked about cleaning. Preferably, we use dedicated equipment. But if we do not have them, then they must be adequately disinfected in between patients. Cough etiquette, we've talked about this. Most important thing is cough into a tissue and discard it in a covered bin. If you do not have tissue, cough into the elbow, because the elbow does not go about touching surfaces. Avoid coughing into the hands. Keeping the environment clean, handling waste correctly. Being careful with sharps is a standard precaution, even though it's not a main thing in terms of COVID-19. Safe injection practices is standard precaution. We should always be careful with them. It's not a main focus in COVID-19, especially because it's not, we don't have it in blood and in blood. Handling linen correctly, beyond the fact that the linen can be contaminated, and if we handle it we can throw it, or you can cause, we can then infect ourselves from contaminated linen. And then occupational health. All staff that will take care of patients should be healthy. Those who are particularly vulnerable should not be put in taking care of these patients, which means the really old ones or staff that have underlying diseases. We should really avoid their being involved in the management of COVID. So our standard recommendations for prevention across both community is regular hand washing, covering your mouth and nose when coughing and sneezing, and avoiding close contact with anyone showing symptoms of respiratory illness. In other words, social distancing or physical distancing. And there is a lot of controversy around that for Africa, but that's for another discussion. However, I would also want to highlight here that there's a lot of focus on the regular hand washing, almost to the exclusion of people talking, when talking about the cough etiquette. we need to emphasize that cough etiquette a little bit more. When you ask anybody COVID, you go to any pharmacy, you talk COVID, everybody is standing around talking, but they are doing the sanitizers, but they're forgetting the cough etiquette and the physical distancing. Those things are, I think, are things we need to re-emphasize and emphasize strongly. Just so that we have an idea, and I'll mention why I said this. Some of the common infections that indicate transmission-based precautions, contact, things like cholera are contact precautions, droplets, meningococcus, and airborne measles and pulmonary TB. I wanted to put this forward because there are many people who are afraid to handle samples of patients with COVID. But we handle samples of patients with tuberculosis, with measles. So it's important for us to get this back into perspective. COVID is droplet and airborne. Under droplet and contact, airborne under certain circumstances. It's not found in urine, it's not found in blood, and even the stool, so far, it's the virus. But it's the RNA. But if we continue with standard precautions, that is adequate for what we need to do here. However, if someone is centrifuging sputum, or if they're taking samples, then they need to wear their N95s. So a droplet precaution, you wear a medical mask, you put the patient in a single room if possible. You ensure that when that patient is being transported outside their room, which you would want to avoid, you have a mask. You inform those where he's going and perform hand hygiene immediately after removing any item. For contact precautions, we use clean, unsterilized gloves, disposable or reusable gown. Remove safely the gloves and gown immediately following any contact, and perform hand hygiene immediately after removing any item of PPE. Dedicate specific equipment for use with single, and always clean and disinfect. Avoid touching the eyes, face, mouth with gloved or ungloved hands, and place patients in a single room or cohort them. Airborne precautions is only for aerosol generating procedures. Things like endotracheal intubation, open suctioning of endotracheal sites. That open suctioning is discouraged, but I do know that sometimes there's no choice. So it has to be done as an airborne. Bronchoscopy, physiotherapy, nasogastric intubation, insertion and removal of chest drains, and conducting post-mortems. So, going back to the beginning, that to achieve the highest level of response, we need an IPC program with a dedicated and trained team, or at least an IPC focal point, and that this program should be supported at the national level and by senior management. I go a step further. There must be a trained IPC person in the EOC to assist with the IPC requirements, to assist with the training, to assist with monitoring healthcare workers, to ensure that they continue to wear their PPE safely, that they're donning it safely, and that they're doing their procedures safely. And irrespective of where one is, one must start the IPC and build up. So the control of the COVID-19 needs a multimodal strategy. And the success in controlling the spread of COVID-19 has come from screening at airports, fever checks through selected population groups, isolation, contact tracing, and follow-up, quarantines, and then designation of dedicated hospitals to minimize the risk of spread and strengthen the IPC. Mass media campaigns to educate the public and encourage prompt reporting of symptoms, and implementation of transmission reduction measures like cough hygiene and hand hygiene. So, if in doubt, we continuously refer to the WHO guidelines. And it says, encourage triage and early recognition and source control. Applying standard precautions for all patients. Engineering and, sorry. Oops. Engineering and administrative controls, as well as transmission-based precautions. So if in doubt, please refer to this WHO guideline. And finally, for COVID-19, prevention is key. We must institute our droplet and contact precautions. We must have airborne precautions for aerosol generating procedures. It is important to have a team and a program in place. Even if there is an inadequate IPC, start where you are and grow till you can have all the components. IPC is a major pillar and should be represented strongly in the EOC and in the facilities. Thank you very much.
Thank you, Professor Gonzalo. We've got some time, so if there's some urgent questions that you want to ask her, we can do that now. If you can just raise your, or just send it to us in the question and answers, and then we can see if we can answer you. Can I maybe say, Sonia Smith, you send a question on, please advise regarding the timeline for retesting of patients. If patients are still treated in a PUI until discharge currently, but this may put a strain on the PPE available. So, Prof. Oguntola,
I didn't hear you.
She was asked, what is the timeline for retesting of patients that have been tested negative initially on admission, they are still treated until discharge? So how long before they have to retest them?
Sorry, I can't hear. Sorry, I've lost. Can you hear me?
Yes, I can hear you.
Can you hear me? Sorry. Hello?
Yes, I can hear you. Yewande, can you maybe, or you and...
Hello, Prof. I can hear you. We can all hear you here. And Hannah, I think you can recognize those people that are raising their hands. As soon as you do that, I'll give them the mic, allow them to talk.
Okay, let me just see who is raising their hands. If we just do that. Okay, raising. Can you see them? Because I can't. I can only see there's so many participants. I can't see them raising their hands.
Yes, I can see them. And if you want me to go ahead to recognize them.
Just go ahead, please.
Okay, thank you. So I'll first recognize Renee Tajad. You have the floor now. You can go ahead for your question.
Just unmute yourself.
Hello? Hello?
Okay.
You can go ahead and unmute yourself and ask your question. Okay, while we are waiting, maybe we can go ahead with Adegoke Akinfeleye. Hello? Hello? Yes, good day, everyone. Adegoke, you can have the floor.
Okay, thank you very much. My name is Adegoke Akinfele. I work for the Lagos University Hospital. I'm a physiotherapist and I also have a postgraduate training in epidemiology. I think my concern is that, like Prof rightly said, standard precautionary measures are not always in place in our health facilities. They are emerging and reemerging infectious diseases. I believe after a while, COVID-19 would go through a phase and be out, at least in the interim, and there may be a reemergence of another infectious disease. How do we prepare moving forward? What are the institutional things that can be put in place to ensure that precautionary measures are taken in our health facilities across Africa? Thank you.
Thank you very much, Akinfele Adegoke. So, Prof, do you want to respond to that, or Anna?
Prof, can you hear us?
Sorry. Yes. Can you hear me?
Yes.
Yes.
Okay. I think I'm back. I don't know what happened. It just sort of froze. I don't know. Can you give me that question again? Sorry. I'm sorry.
Okay. If I'm allowed to, am I on?
Please,
yes.
Go ahead.
Go ahead. Please say it again. I'm sorry for.
Okay. I just introduced myself, and I said I'm a physiotherapist as well. I have a training in public health epidemiology, and I work in a hospital setting. I've observed that over the years that in our health facilities, standard precautionary measures are not always in place. COVID will pass through this phase, and there will be reemergence of another infectious disease. What institutional measures is the African CDC putting in place to ensure precautionary measures, standard precautionary measures are in place in our health facilities across Africa? Thank you.
Oh, that's for African CDC.
Yes.
Oh, okay. Well, I thought African CDC would answer that.
Yeah.
All right.
Okay, thank you very much.
For African CDC.
Hello, this is Dr. Mohammed Abdulaziz. Can you please repeat? And if Yewande is on the call, Yewande can answer.
Okay, thank you very much for your question. Just very quickly, in terms of what we are doing, I noticed that your question doesn't really focus on COVID as such, but looking at the holistic emerging and re-emerging. So as Africa CDC, one of our key strategies is to make sure that all of the 55 African countries have what we call the National Public Health Institutes, and they are properly strengthened to actually respond to any form of outbreak. So we have been working with countries to ensure that every country has that. Many countries now have, over 20 countries have National Public Health Institutes. Nigeria does have the Nigeria Centers for Disease Control. Similarly, Liberia, South Africa, Kenya very recently, Zambia Public Health Institute too. So all of these institutes are strengthened to respond to emerging infections or outbreak. As we have seen with the COVID response, many African countries have been able to respond by themselves, not needing external support as we have done in the past. So I think that is the strategy as Africa CDC that we are doing, is that we are strengthening the countries to actually be at full capacity to respond to disease outbreak. I hope that answered your question. We'll take the next one.
Sorry.
Sorry, can I just, to be more specific for IPC, Africa CDC trained about 50 African countries.
Sorry, there's somebody's
hello?
mic on that's making noise.
Okay, thank you, Prof. So Africa CDC trained at the national level 40 African countries on IPC, and we were just about to start supporting the step-down training when the outbreak, the pandemic got to Africa. But I think as part of the AFCOR IPC activity, we will be doing step-down training in some specific countries as we go ahead. So Africa CDC will continue to support IPC in both at the national and sub-national level. Thank you.
Okay. Sorry, before we go on, somebody was asking a question. I heard a part of it, and then
Hello. Hello.
Hello.
Hello. This is Zakaria Gansam from Burkina Faso.
Okay.
I have a question.
Go ahead, please.
Okay, thank you very much for this opportunity to learn more about COVID-19. We'd like to ask a question about the place of air technology, air disinfection technology against COVID-19. Do you think that it is possible to use this kind of device to control airborne disease in Africa?
Sorry, I'm not sure. What you said? Can you ask that question again?
There is some air disinfection technology which can be used to control the airborne disease in hospital. I'm asking if do you think that this is possible in Africa context?
First of all, let me just COVID-19 is not airborne. It's not an airborne disease. It's a problem. Yes. But I don't know this technology you're saying. I don't know. Maybe I don't know what you mean by the technology to counter airborne diseases.
Excuse me.
Yeah.
Hello?
Hello?
Yeah, I just want to ask for a general hospital. It's not specific for treating patients with COVID. So does every patient entering the hospital should wear a mask? Patients. It's not for the healthcare workers.
I can say that straight off, that I would say no.
I'm sorry?
I said straight off, I would say no. I would say no, and I'll explain why. If there is adequate social distancing, if the patients are taught to do their cough etiquette, in other words, cough into if you have symptoms, if we do good screening and separate patients who have been exposed, then you don't need every single person coming into the hospital wearing a mask. So technically, we haven't got there yet, but technically when you do a triage and you're screening at the entrance of your hospital, the idea is to identify those who appear to have symptoms and may have had exposure and move them away from others. So technically, I do not think everybody needs to be wearing masks coming into the hospital.
Yeah, and is it better to decrease the number of outpatients or decrease the number of inpatients for a general hospital? So I know we should decrease the number to have an efficient healthcare worker effort. So it's better to decrease the outpatients or decrease the inpatients number?
I think it depends on the stage of your epidemic. If you're just having if you have not started having community transmission, and you can almost define where, you know, you can say this is, you're still having clusters that you can identify. There's no need really. But once you have community transmission and you really don't know where patients will be coming in from, yes, it will be a good idea. In fact, it is recommended that you limit non-emergencies, if I may say so, or designate cases for special places, for special hospitals. But I would say, yes, depending on the level of your epidemic. If you already have community transmission, it will be a good idea that people who don't have to come to hospital at all shouldn't come.
Okay, thank you.
Yes.
So Mohammed Ismail, you can go ahead and unmute yourself and ask the question. Can you hear me?
No.
Mohammed Ismail.
Okay, I heard your name, but have you asked the question?
Yes. No, I'm telling the Mohammed Ismail to go ahead and ask this question.
Can't hear. Hello?
Hello?
Okay, if Mohammed is not on, Prof, can I ask my own question?
Yes.
Yes, Prof. Please, is there any evidence on, because I've been asked this question quite a lot on the field, well, any evidence of the effect of weather? Or when I say weather, I'm talking about temperature and humidity on IPC, infection transmissibility, especially as regard COVID-19. Any evidence in the literature or from your vast experience and practice to say something about this? Over, thanks.
Well, considering that COVID is an evolving epidemic or pandemic, but it's now in Africa, which is warm and humid, and it's spreading. I doubt it. I really doubt it. But I mean, we do know that flu viruses have seasonality. I think we still have to spend quite some time evaluating this particular virus. It has to go through the seasons for us to see if there are changes. But I don't think temperature alone will solve it. Nigeria, where I'm sitting, is very hot and humid, and our cases are growing. So I'm not sure. And if you think about the way it is transmitted, technically it's going from one person to the other. So it's probably just flying into the other host. So I don't know the impact it will have on the contamination of surfaces, if you understand what I'm saying. But right now, I don't think we have enough evidence to say that. And I'm not sure, just anecdotally looking around and seeing what is happening. Can you hear me? Hello?
Hello, we can hear you. Please continue, Prof.
Yes. So from what we are seeing, this particular virus is everywhere, in the warm countries, in the cold countries. So we have to, I think this is something we will determine later. I don't think it's something we can be very clear about. I haven't seen much of a difference in temperature or the impact of temperature. I think that came up more at the beginning when it seemed to be slow to come to Africa, but it's there now. It's everywhere now. So I'm not sure it's significant in terms of whatever impact that might have. Hello?
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 Hello, yes. Go ahead with your question, Kwanzu.
Yeah. Oh.
Okay. Right. Hello, can you hear me?
Yes.
Right. My question will be centered on the airborne nature of COVID-19, because I've seen on the WHO website that it is
Sorry, I can't hear you anymore. That it is.
Hello.
Hello.
Hello. Can you hear me now?
Yes, you said WHO website that.
I said it's about the airborne nature of COVID-19. So what I mean, your presentation, I've heard that you have mentioned it twice, that it is not airborne, but it can be transmitted through droplets within the air. So, but also CDC is currently recommending that people should, in fact, use
Okay.
cloth masks, actually practice
Yes.
distancing. But also, the WHO also it is doing it, but not to emphasis on using masks.
No.
So what I'm trying to ask here is like, is it recommended in terms of IPC to use cloth masks in the event that they are in public and they cannot practice? You've made some points about it not being airborne, but it can be suspended in the air.
Let me say something straight away. I do not. Right. The WHO has never said that COVID-19 is airborne. It says that COVID-19 can be aerosolized when you're doing certain procedures. They are very different.
Okay.
Yes.
So my question here is, what makes it an airborne? Is it
wow. Okay.
Is it when you catch some diseases simply by breathing, or
let me explain.
What is peculiar about it?
It's about the size
airborne in terms of.
Okay, I think we made some certain assumptions. Otherwise, I might have shown some other slides that would have explained the difference between airborne and droplets, because we were trying not to be too basic. The difference between airborne and droplet, the main difference is that the size of the secretions that come out are larger in droplets. So it still passes through the air, if you get my point, but it is big, so it drops not too far from the person that is coughing it out. Do you understand? Whereas for airborne, it's mostly very tiny droplets, and it's so light, it continues to float. The main difference in terms of the way you catch, you can be infected, is that in droplets, you need to be in proximity. You need to be close enough to the person. And so it's going to land on your mucous membranes, and then you take it in, Whereas airborne, the person may not be in the thing is lingering in the air because it's so light, it's just floating around. So you could catch it even when the person who had the infection is no longer there. So it's about the size of the droplets and the fact that one lingers in the air for a long time, whereas the other one does not. But we also recognize that in certain situations, some of the procedures we do in the hospital can cause the droplets to become very fine. And so in those cases, you go for airborne precautions. And the main difference between airborne precautions and droplet precautions is really about the mask, N95 as against a medical mask.
Good morning.
Good.
Yes.
Great. Thank you, Professor. Can you hear me?
Yes, I can.
Yeah, hi, this is Nicholas Adamaka. I'm an infectious diseases doctor, worked for many years and currently working in the pharma industry in Germany, originally from Ghana, West Africa. Very good talk. Thank you very much for this great overview. My question is kind of fundamental, really, about whether or not this is exactly the kind of playbook that is applicable to the Africa setting. My experience, I have to say, is limited, but from all I read, you know, this whole foundation of an enabling environment where you have sufficient resources, we're talking a lot about PPE, and as we see in the West even, you know, PPE is a major problem. If we're assuming that the Africa scenario is going to play out like it has done in China, in Europe, and in the USA, where the enabling environment is clearly significantly more robust, you know, can we really expect that we could work to this similar playbook, these similar processes and theories in Africa, and expect any kind of win, let alone a similar scenario to what we're already seeing as a sort of devastating pandemic in those other regions?
Thank you very much. I think, and I hope that we do not, that scenario does not.
Agree fully, yes.
However, what I'll also want to mention is that the strategies for IPC, and that's why I think for Africa, we really need to face the prevention. The strategies for IPC, most of them in the main are not rocket science. Most of them in the main are not expensive. Most of them. And so is it, I mean, is it hand hygiene? Is it cough etiquette? So where I'm going is a lot of these things, cleaning the environment, you know, it's when we get to case management and when we now have those major, very ill patients, we're going to have more of a major problem. But that's, please, I haven't finished because I still have, before people say, are you sure? We also have poverty. We have community. And I know we had a discussion, it was a webinar about 2 or 3 weeks ago, which we had been thinking about in ICANN. When you get to places where 30 people live in one house, where people take turns to sleep in their rooms, when their livelihood is dependent on going to the market, and in the market you have 1,000 people, 500 people in close proximity. How do we do this social distancing, lockdown, and so on? If I say I have all the answers, I don't. I will piece this with what the last person asked. So, however, the requirements to reduce transmission are cough etiquette, that doesn't cost a dime. Washing your hands, that might be challenging because some people don't have water. So maybe governments need to invest in alcohol hand rub and make sure people have it. We tend not to promote chlorine as a hand hygiene. That's an ICANN position. But we recognize that if you don't have anything else, it is certainly better than not being able to clean your hands. Social distancing or physical distancing will need a lot of communication and talking to people. But all these, and then the one that's been touted, cloth masks. Let me say that the evidence for cloth masks as protective, very protective, doesn't exist. People have studied cloth masks. And some of the best studies that showed what cloth masks could do talked about certain things you needed to look at. The weave, how tight it is, that by the time you're using it, it should be a little difficult to breathe. But the best, when it was tested, and it wasn't tested for COVID, was it was 50% as good as a medical mask. Most of them were like 30%. And some of them were frankly absolutely useless. However, what was also found was that it was still better. In terms of, does it protect you? The answer is probably no, but it could reduce secretions and transmission from, from a person who has the infection. So those who are talking about cloth masks, and I have to say that it is looking attractive to me, and that's a personal opinion, and I think it's shared by a lot of us who have to worry about how do you do social distancing in our setting, is that if we add that onto, not alone, to all the other things, and message it properly and package it properly, and recognize that there is a downside, that people may think that once they've worn the cloth mask, they can do anything, then I think it might help. But there's a big caveat. If you promote cloth masks, it has to be part of the package, and you must work against ensuring, and that message must be so clear that it on its own is not protective enough. So I recognize that all this social distancing assumes that you have a house, you can move into it, you can get away from people, you can, you have places where you can stand 1 meter apart. It doesn't happen in many places. Once it gets to certain levels in Africa, it won't happen. They can't even be 1 meter apart. It's so densely populated. So it's still something that everybody is talking about. I know cloth masks has been promoted by the CDC in the US. I know South Africa has something that's come out on cloth masks. I suspect Nigeria is going to come out soon. My thing is, I think it can add a layer, in the sense, because we don't have a choice, but it must be properly messaged so that we don't have people thinking just wearing the mask allows them to do risky behavior. I don't know if I've helped. Oh, let me also mention that, again, we may be a little lucky because our epidemic is coming behind a lot of places. So now we know about how to disinfect N95s. We're learning how to do extended use. These were things we were doing before, maybe not documented, but now we have guidance as to how to do those things properly so that people are safe. So I think, I don't know if I've answered you well. I'm not sure there's any clear answer, but I hope I've put some thoughts in your mind.
Thank you so much, Prof. And personally, I really appreciate what you've done and the presentation. Because of our time, I think we won't be able to take any other question now. You can continue dropping your question in Q&A and also the Telegram group that we have. So over to you, Anna. Thank you.
Yes, thank you very much. Answer some of your questions. Some of them is not so easy, but we will work through them and get back to all of you. And if you do need anything, you can contact us directly. If you go onto our website, you'll get our email addresses, and then we will see you guys, if possible, next week, same time, that we can carry on this great discussion and assistance to help you in your fight against COVID-19. I want to just thank Professor Ogunsola that took this time out of a very busy schedule. Thank you very much for this presentation. Thank you for Africa CDC that was assisting us, and Africa Union with putting up this webinar together and helping with all the technical assistance. And thank you for everybody that joined us. Have a great day. Adiwa, are you still there?
I am. I'm answering questions.
Yes, no, I just wanted to make sure we're all on that. I see the people
will I get these to, will I get these?
I am also answering some questions. Some of them seem to be on the chat, not on the Q&A. So you'll be able to also go to the chat to see what questions have been put there for us.
Yes.
Yolande, can I just maybe ask, is it possible that we can maybe have them on a document with all the questions and the answers, and then we can maybe just make sure that we didn't miss anything, that we can...
Yes, definitely. Susan is going to make that available for all of the questions on the Q&A, and some questions that came out of the webinar chat. We will put that on a Google document for everyone to access, and she'll be sending the presentations later today.
Yeah, no, great. Very much for all your assistance. Thank you, Susan, and thank you, Adwa, as well.
Okay. So I see quite a number of questions. I'm just going to keep putting the Telegram link. We probably need to decide what time we would like the office hours to be.
Yeah.
Which office hours?
On the Telegrams, where if they have like key questions,
oh yeah, I have to join. Yes. Oh, the other thing I wanted to say was I agreed with Emilio that we maybe should meet maybe tomorrow or Saturday morning, so that we can just go through and decide how the others would be, because there were gaps, so that we just keep fine tuning, because from the discussion, it was clear there were people there that were not IPT, you know?
Yes, I definitely agree with you.
Yes, so, because I actually took out slides that, you know, because I spoke with Emilio, and it was that we were trying to get away from too much basic, you know, too much science, and more about what people should do. Even though this was an overview, I was trying not to be too, you know, too fundamental. That's because I looked at the original. So did it still come out okay? Because I took some things out.
Since we are going to share the presentation with them, we can put some of the basic things back on.
Okay, I will.
Yeah, so that it's more comprehensive and they can always reference it.
Yes, okay, I will do that, because I took some of these things out because I was trying not to be too, you know, basic.
Can I just suggest something as well? Maybe we can ask the participants as well that they can send it to us. But I think if you look at some of the suggestions as well in the comments, that a lot of them enjoyed being more practical, and this is what they need. So that make sure that we do it over a period. And if they give us some feedback on how they feel, do they want some more, do they want less, then we can take it also from there.
Okay.
Okay, so yeah, we can do that.
Yeah.
Susan, are you online? Susan? Yeah, Susan.
Sorry, I muted my phone. Yes.
Okay, sure. Is it possible for us to create like a Google Sheet or something for people that join today's session, so that if they wanted something more practical or things like that, or if they had like key areas that they were interested in, we can get some sort of feedback. I don't know if you can kindly think about that and come up with something for us. No, thanks.
Yeah, Yolande?
Yes.
My thought really is that all the other weeks should be practical, more practical. I felt that this one should have, it was just the overview, will not be necessarily practical, but just